Hi everyone, today we're going to talk about Section 3, Eye Problems, and this section starts on page 259. The first thing that we're going to start with is dry eyes. This is a disease of the tears and eye surfaces that can be caused by many different factors. These factors can cause discomfort, visual disturbances, and instability of a thin fluid layer called your tear film that covers most of the eye. Simply, it's when the quality and the quantity of tears do not keep the surface of the eye lubricated. The book lists several different system questionnaires that you might be able to use to help with the diagnosis of dry eyes, and those are found on page 260. Be sure and review those because there's many differential diagnoses that could be used when working up a dry eye. And these could range from infection to inflammation to neurological conditions, hormonal changes, and vitamin deficiencies. Another eye condition is excess tearing, epiphoria, and that's when you have too many tears from one or both eyes, and they can be the result of a response to dry eyes, an exposure to something that's irritating the eye, or an obstruction of the tear duct. Next, let's talk about some eye pain, and one of the key things with eye pain is determining when is the time to refer to an ophthalmologist. In your book on page 261 on table 18A, the book lists conditions requiring immediate referral to an ophthalmologist, and with any patient that complains of severe or sudden vision loss or sudden severe non-traumatic eye pain, those need to be referred. On your physical exam, you may note some corneal ulcerations. There may be irregular shaped pupils, a hazy cornea, elevation of the fundus on a fundoscopic exam, papilledema. So be familiar with what you feel comfortable with managing in primary care and what needs to be referred out. The most common cause, though, of eye pain is trauma. The next condition we're going to talk about is red eye, and it's very common in primary care, and it's a non-uniform redness of the conjunctiva from hyperemia. And the most common cause for red eye is viral conjunctivitis, or what we know as pink eye. Other causes of a red eye could be bacterial infection, chemical irritation, allergies, or irritation from inadequate sleep, overuse of contacts, lenses, irritants, and excessive rubbing of the eyes. Patients can also present in the office with complaints of visual disturbances or impaired vision. While there may be a long list of conditions that may alter your vision, some conditions are very common. It's important to feel comfortable with these in primary care. So the first one are floaters and flashing lights. And floaters are usually due to the contraction of the vitreous humor in the eye, and they are more common in the aging process. They also can result, when we talked about earlier, that tear film layer, there may be debris on it. Floaters are usually one eye only and are often seen while looking at a bright background, and floaters can appear gradually and become less noticeable over time. These are often considered benign and require no treatment. Next, let's talk about flashing lights, also known as photopsia, and it's a subjective sensation with sparks or flashes of light. And any patient that complains of these symptoms needs to be promptly evaluated for retinal tears or detachments. At the end of this chapter, on page 262 and 263, are some tables that have some concise information on causes of red eye, and then also one selected causes of impaired vision. And so just be sure and review those, because those are tidbits that you may find helpful in practice. Next, let's talk about some conditions that impact the eye or the conjunctivitis. First is blepharitis, and this is an inflammation of the eyelid and the margins of the eye. There are two forms, a non-ulcerative form and an ulcerative form. The non-ulcerative is associated with seborrhea of the face, and you will see a greasy scaling along the eyelid margins. And the ulcerative form may involve the eyelash follicles and the meibomian glands of the eyelid. On presentation, the lids may be swollen and red. When you look closer with a magnifying glass or a Woods lamp, you may see some scaling, some ulcerations, and some redness. On box 19.9 on page 265, there is a table that describes the treatment for this condition, and that is going to be based on the cause, whether it's non-ulcerative, whether it's infectious, etc. So be sure and review that. Any eye swelling or inflammation of the eyelid that does not resolve promptly, typically within about 4 weeks, needs to be further evaluated. And if you put patients on medication, it's important that you reevaluate them in 2 weeks. And if the symptoms are improving, then they should be reevaluated again in a couple of months. The next conditions we're going to talk about are hordeolum ankylosing. Hordeolum is also known as the stye, and it's inflammation or infection of the eyelid margin that affects the hair follicle or the eyelashes. The chalazion is a granulomatous infection of the meibomian glands that presents as a painful swelling of the eyelid. Subjectively, the hordeolum can have localized tender inflammation and redness at the margin of the eyelid. And the chalazion commonly presents slowly developing, and it's painless, but it can have a hard mass that has inflammation and can involve the surrounding tissues. When you have these patients in practice for chalazion, it's important to roll the eyelid back a little bit. Inversion of the eyelid can often reveal a reddened mass that can be quite large and can press against the eye. With the hordeolum, you can have localized tenderness if you palpate it, and there may also be drainage from the lesion. You may also be able to palpate some preauricular lymphadenopathy. Initial treatment for both of these conditions is warm compresses. If you find that there is infection or inflammation, then erythromycin ophthalmic ointment may be prescribed. There is a table or box on page 267, 19.9, that gives more information about this. Next, let's talk about dry eyes. These can be either congenital or acquired, and acquired may be something systemic like Sjogren's syndrome. It could be related to an infection, or it could be related to some trauma of the facial nerve, such as Bell's palsy. These patients that have chronic dry eyes have an increased activation of the T cells. T cells are known to produce cytokines that can result in a neural signal to the lacrimal gland that disrupts the production of tears. And certain medications are known to decrease tear production. These include anticholinergic agents, beta-adrenergic blockers, and antihistamines with anticholinergic effects. Most patients that present with dry eye symptoms often feel like they have sand in their eyes, especially when they're blinking. All of your eye conditions that we're getting ready to talk about, they all require that you evaluate for visual acuity as part of your objective findings, because that's going to help determine or give more information for your differential diagnosis. The management of patients with dry eyes is going to be dependent on the cause. If there is a systemic medication that can contribute to the dry eyes, then that needs to be considered to eliminate. There are different levels of treatment for dry eyes that are based on the severity of the condition, and these are found on page 269. First, it's education and making changes to the environment and dietary modifications. If first-line therapy does not work, then the second level of care would include pharmacological measures, including lubricants and artificial tears, but also adding in anti-inflammatory or immunomodulatory agents. You may have seen these advertisements on TV. They're topical cyclosporins, one brand name being Restasis, and it's used to treat chronic dry eyes. And it has small concentrations of cyclosporin that is felt to inhibit the activation of T cells. And third level of treatment is when previous levels did not control symptoms. These levels consist of special contacts, surgery, and using autologous serums. The next condition we're going to talk about is excessive tearing, epiphoria. I see this quite a bit with my oncology patients, that they will come in and be complaining of all this tearing, and it turns out that it is a response to dry eyes. Your body is trying to compensate for it. These patients feel they always need to have a tissue or a handkerchief with them because their eyes are continually dripping, and they feel like they are always having to wipe their eyes. Objectively, as we mentioned before, in visual acuity assessment needs to be completed. An exam of the structures and the surrounding tissues of the eye needs to be considered. You're looking for swelling, redness, discharge, rashes, and any structural abnormalities. You're also looking for any foreign bodies or corneal irritants to rule out that as a cause for excessive tearing. If the excessive tearing is secondary to a trauma or infection, you're going to use antibiotic drops. Steroid eye drops and anesthetic drops should be avoided, as they may block healing and increase the risk of infection. Eye rest is very important. Eye patching, though, is no longer used as it previously had been and is not recommended. If the excessive tearing is related to allergies, then managing those symptoms is what is recommended. Using cold compresses also for comfort and to help relieve the itchy eyes. If the excessive tearing is related to a foreign body and it can't be promptly removed in the primary care setting, then the patient needs to be referred to an ophthalmologist or to an ED within 24 hours. And if it's felt that the excessive tearing is related to a corneal abrasion, then the eye should be reevaluated in 24 hours as well. The next thing we're going to talk about is red eye conjunctivitis, which is the inflammation of the conjunctiva that covers the front of the eye. It is probably going to be one of the most common eye issues that you see in practice and can affect all ages. Risk factors can include trauma from the wind, heat, smoke, cold, chemicals, or foreign bodies. One thing that is important to remember with conjunctivitis is that depending on the causing organism, it can be transmitted very easily by contaminated towels, washcloths, or even the patient's hands. So hygiene is very important. Symptoms that you see are going to be based on the cause, but most patients present with itching, watery, and redness to the eye. There can be that sensation of a foreign body or a sense of fullness in the eye. Bacterial infections are caused most often by Staph aureus and can produce a thick yellow sticky drainage from the eyelids. Bacterial infections usually are to one eye, whereas viral infections can appear in both eyes. As we've mentioned, when you are doing your assessment, the first thing is to assess the visual acuity of both eyes as well as each eye individually. You may note the hyperemia, that redness and tearing. There may be eyelid swelling. You may note preauricular lymph nodes if there is a viral etiology such as herpes simplex virus or an adenovirus. We always check for visual acuity, and a dilated pupil exam, the book states, should be performed by a trained professional in patients that have that redness of the eye, that also may have some bulging or protruding of the eyeball called proptosis. If there's any optic nerve dysfunction, decreased visual acuity, diplopia, or any anterior chamber inflammation. You may use some fluorescein staining to see if there's any corneal abrasions. In the book, on page 274 under differential diagnoses, it mentions ways to help determine which type of conjunctivitis you might be seeing, and it refers you back to differential diagnosis 18.1 in the previous chapter, but I cannot find one for a comparison of selected red eye. Actually, I take that back. There is one on page 262, selected causes of red eyes, and it does break it down into bacterial, allergic, viral, iritis, or acute glaucoma. So be sure and look at that. It talks more about very nicely in a grid form with allergic, conjunctivitis. You could have a mucoidy, stringy discharge, normal visual acuity. You may have itching and burning. So it might be very helpful if you're seeing these type of patients in practice to have a snippet of this table, so you could kind of go and go down a column and figure out which diagnosis you have. Treatment is going to depend on the cause and the impact on the patient's vision. If you have any drainage, purulent discharge, or debris, that needs to be removed, and then lubrication of the eye with artificial tears is recommended. With any eye condition that has discharge, the patient should be instructed not to wear contacts. If they should wear those, they all should clean the margins of the eye with a diluted no tears shampoo to help keep the eyelids as clean as possible. Cold compresses are often very beneficial to the eyes. If there are allergic or irritative conjunctivitis, if there is something that is more infectious, warm compresses may be helpful. The bottom line is what it feels best to the patient. On page 272 in drugs commonly prescribed for conjunctivitis, there are different categories of medications that might be used, and then the different drugs for the particular category. So I encourage you to review that. The last chapter of this section is visual disturbances and impaired vision. And while you are not going to be assessing for refractory issues, prescribing glasses, etc., it's important to know some of the conditions that may be associated so that you can be more aware in your treatment or when you need to refer. We know that normal vision is dependent on clear images getting to the retina. When we have refractive errors in our vision, we can have blurred vision due to the aberrations in how external light is reflected into our eyes. Subjectively, these patients are going to say that they've had a change in vision. It could be gradual and should not be accompanied by pain or redness. You would want to check their visual acuity with the Snellen eye chart and see if it has changed from the last time. And there's also a simple test that you can do in practice. It's called a pinhole test, and it can be used to determine whether there's been a change in the visual acuity or if the result of the refractory error is caused by something else. And in the pinhole test, you take a stiffer piece of paper or cardboard, cardstock, and you create pinholes anywhere from 0.5 millimeters to 2 millimeters, and then you ask the patient to look through the pinholes one eye at a time. And if the visual acuity improves without corrective lenses, then this change in vision is considered a refractory error. And if there's no improvement in vision, then the cause could be considered more organic. As a review, cataracts are an opacity of the lens of the eyes, and they may or may not be associated with visual impairment. When there is decreased visual acuity, it's caused by the breakdown of the crystalline lens, and this is what will affect someone's vision. The patient may present with changes or functional impairment, but they can also have asymptomatic cataracts that can be found on a routine exam. Currently, there's no non-surgical treatment for cataracts. Cataract surgery is relatively safe as an outpatient procedure and has been shown to be highly cost effective. Your role in the management of cataracts may be for preoperative clearance based on comorbidities that your patient has. So if you do receive a request from the surgeon for this, it's important to do a physical exam, possibly do an EKG, check electrolytes, etc. to give clearance that they are okay to have surgery. Patients that do have cataracts need to have an early referral and be monitored by an ophthalmologist. Next, let's talk about glaucoma, and we know that's the progressive damage to the optic nerve that results in nerve atrophy and blindness, and it's most typically associated with elevated intraocular pressure. There are two forms of glaucoma: open angle glaucoma and angle closure glaucoma. Open angle is the most common type, and it's characterized as a chronic form that before the patient loses peripheral visual fields, it's typically asymptomatic. These patients have an excellent prognosis if treated appropriately early. Angle closure glaucoma, on the other hand, can have a subacute and chronic components, but it is most often associated with acute episodes of significant eye pain, redness, and acute visual loss, and if untreated may rapidly lead to permanent blindness. Physical diagnosis of glaucoma relies on a special evaluation by the ophthalmologist called a gonioscopic exam. And this is going to assess the angle of the eye's anterior chamber and help differentiate between open angle and angle closure glaucoma. The goal of treatment is to prevent progression of damage, and with open angle glaucoma, it's typically managed with pharmacological options. On page 284, there are drugs commonly prescribed for glaucoma. Not that you are going to be prescribing these drugs, but it's important to know what the drugs are being used for so you can help your patient to be compliant with them. First line therapy is typically a beta blocker drop, but there are also prostaglandin analogs that are being used. Treatment is very common to have several different eye drops that you have to use quite frequently, and compliance can be poor. Next, let's talk about diabetic retinopathy. And this is a non-inflammatory disorder of the retina that develops due to diabetes. It's typically divided into 3 stages. You have the background stage, the pre-proliferative diabetic retinopathy, and the proliferative diabetic retinopathy. Changes will be noted on the fundoscopic exam, and that's why it's very important that diabetics keep their blood sugar well controlled, because changes can be seen in the eye, and also that they follow up with their eye doctor annually to have a thorough exam. In the background diabetic retinopathy phase, you can have microaneurysms and intraretinal hemorrhaging. There can be macular edema. There can be deposits of lipids. As the disease progresses, nerve fibers can have infarctions, which are called cotton wool spots. There can be dilation, edema, and in some cases, extensive retinal hemorrhage can be noted. In the proliferative form, new blood vessel proliferation, there's neovascularization, may be seen on the retinal surface, the optic nerve, and the iris. Management of this condition is prevention, and so it's a real risk if you have patients that have their blood sugars greater than 200. It's important to keep their hemoglobin A1C less than 7, and as we talked about previously, refer to ophthalmology. And also, one interesting note is the only pharmacological agent that has been found to slow the progression of diabetic retinopathy is lisinopril. And lastly, let's talk about macular degeneration. It is considered a disease of the aging, and it's the leading cause of blindness in patients older than 60. The book lists several risk factors: Caucasian, female, older than 60, cigarette smoking, family history, and having a macular degeneration gene. Other factors that are unproven but have been documented in some studies: high cholesterol, obesity, exposure to ultraviolet light, hypertension, light colored eyes, farsightedness, and previous cataract surgery. There are two forms of macular degeneration. There's the dry, which is a slow progressive atrophy and degeneration of the retina, and then there's a wet, which is age related and is where new blood vessels develop under the retina in the macula, and this can cause distortion and loss of central vision. As a provider, one of the key things is to determine the onset of visual impairment. Has it been acute or has it been gradual? And this is going to determine what your next step will be. If there's been a severe visual loss, then that requires an immediate referral to an ophthalmologist. As we've mentioned with all our tests, you need to have a good visual acuity test taken. You're also wanting to evaluate all of the external structures of the eyes. Analysis of the central vision may be done with an Amsler grid, and this is used to locate macular blind spots. There are no proven strategies for preventing macular degeneration or treatments in the early stages, but there is some evidence that has shown that in the intermediate stage of the disease, oral intake of high-dose antioxidants and zinc supplements moderately decrease the risk of developing severe vision loss. If you have these patients, it's important to refer them for rehabilitative sources to help manage daily living needs. That's the end of the chapter, but on page 289, there are two vignettes that I encourage you to read. One is a nursing situation with a gentleman who had a severe visual impairment and how his story went, but one that I felt was very heartbreaking is from the patient's voice, and it talks about the mother who called her daughter in a panic because she could not see out of the eye. Out of one eye. Her ophthalmologist got her in, and when the daughter and the mother met with her, the doctor stated that the patient had been told that she had had macular degeneration diagnosis 4 years ago, and the mother had never said a word to her daughter, and how maybe some changes may have been appropriate along the way and better acceptance of the condition, but the big concern was what were they going to do if there was loss of vision to the other eye. So it impacts not only our patients but our families and how our older patients are going to be cared for. So anyway, end of this section, and I appreciate your time. Thank you.